Hello everyone, welcome back to the PriGina Medical YouTube channel. Today we are launching a brand new series of uploads focused on high-yield USMLE concepts to help you master the exam. And as promised, we will dive into key topics starting with essential GI concepts. These videos will provide valuable insights to support your studies. So today we are going to start with Tracheoesophageal Fistula, which is a high-yield topic that normally appears on the exam. So our table of contents, we are going to define TEF, and then we will talk about the pathogenesis, clinical features, diagnosis, management, and at the end, we are going to discuss some USMLE case scenarios. So what is tracheoesophageal fistula? I'm going to be referring to it as TEF in most of the slides, so kindly pay attention. So TEF is a condition whereby there's abnormal connection between the trachea and the esophagus, which causes problem with breathing, swallowing. So due to this connection, food or liquid may enter the lungs instead of the stomach. This usually occurs due to a defective division of the foreguts into the esophagus and trachea during embryogenesis. And then this results in proximal esophageal pouch and fistula between the distal trachea and esophagus, which is often associated with esophageal atresia. I have some pictures here that we can quickly go through in order to understand what I just defined. So we have our normal esophagus here, long, nice tube, and then we have a trachea over here. But with tracheoesophageal fistula, there is an abnormal connection between the esophagus and then the trachea, as we are seeing here. And mind you, there are different types. So these are a few different types that I have placed here. We have atresia with a distal fistula. So over here, we can see that the upper portion of the esophagus has been cut off. So it's not forming the long, nice tube that we saw here. And then the lower portion of the esophagus has rather been connected to the trachea. Hence, if there is any food content over here, it's entering directly into the trachea, which is also known as the windpipe. And then any food over here, it's not able to come straight down into the lower portion of the esophagus due to the cutoff that we can see here. Also, in another type of TEF, we have the atresia with double fistula. So we have the upper portion of the esophagus and the lower portion both connected to the trachea. You can also have an atresia with a proximal fistula where the proximal part of the esophagus is connected abnormally to the trachea. So either way, you can have air entering into the esophagus and then into the stomach, or you can have food from the esophagus entering into the trachea. Okay, and there's also another picture here, same proximal esophagus connected to the trachea, distal esophagus connected to the trachea. So for the clinical features, look for regurgitation with initial feeding attempts. There could be coughing, choking, and vomiting with feeds in such babies. There could be excessive drooling, and then this is normally associated with VACTER-L. VACTER-L is just a mnemonic or a short form of remembering other abnormalities that can be associated with TEF, and this is very high yield because they can give you a baby with TEF and then ask you what other screening methods you can use to find any other abnormality associated with the condition. So V stands for vertebral anomalies. We have A for anal anomalies, cardiac anomalies for C. We could also have a renal abnormality or limb defect seen in patients with TEF. So please take note. To diagnose the condition, your first step is to pass an NG tube followed by an X-ray because you want to see if the NG tube is going to pass without any resistance. So if you see that the tube is in the proximal esophagus or there's an inability to pass the enteric feeding tube into the stomach on X-ray, you can confirm your diagnosis. And then if you see that there's gas-filled stomach seen on an X-ray due to the inflation of the stomach from the fistula from the trachea, this is also another way that you can confirm the disease. Also, when you do a prenatal ultrasound and you see polyhydramnios, it could be pointing you to the condition because the fetus is not able to swallow as much amniotic fluid as it should. So the amniotic fluid piles up leading to polyhydramnios. So I just put in this picture here again so that we can understand the X-ray findings. So as you are passing an NG tube here, it should go smoothly down into the stomach. There is no resistance. But if you are having an atresia, this tube can coil up here, and then you find out that it can't penetrate to the lower esophagus then into the stomach. Also, you meet resistance here if you have an atresia with double fistula, because there's going to be difficulty passing the NG tube down through the esophagus, same as an atresia with a proximal fistula. So any form of TEF can cause resistance in passing an NG tube. That's why the initial step is to pass the enteric tube and then do your X-ray to confirm the diagnosis. So this is an X-ray which is showing the enteric tube in the proximal esophageal pouch due to the difficulty in passing it down as a result of the fistula. So you can have an X-ray like this in the exam, which is very common, or you can have an X-ray like this where the tube is coiled up right here due to the atresia, as I explained earlier. To manage this condition, you have to do a surgical correction and also make sure very high yield to do a bacterial screening. So for vertebral anomalies, you want to do an ultrasound of the sacrum. For anal atresia, you would have to do an X-ray. Cardiac defects, you have to screen by doing an echocardiogram. And then if you are screening for renal abnormalities, you have to do a voiding cystourethrogram. And then for limb defects, you have to do an X-ray of the wrist. So it's also to say that whenever you are having a patient with anal atresia, cardiac defects, or any of these, you also have to screen for TEF with a catheter, enteric tube, or the X-ray. All these abnormalities are usually coexistent, so if you find one, you have to screen for the rest. Lastly, if you do an esophagography, it may reveal the pooling of water-soluble contrast medium in the esophageal pouch. So kindly take note of that as well. Okay, we will be discussing some USMLE style questions for the day on how a question usually is asked about TEF. So we have a 2-day-old infant who is brought to the emergency due to choking, vomiting, and coughing episodes with attempted feeding. The baby has a history of excessive drooling, and on physical exam, the patient has a distended abdomen and appears to be in respiratory distress. Patient has coarse breath sounds bilaterally with intercostal retractions, and then cardiac exam reveals a grade 2 out of 6 systolic murmur at the upper sternal, left sternal border. So this is a typical way that they could ask you to diagnose TEF. So like the clinical features we spoke about, this patient has choking, vomiting, coughing, and all that going on. And then we see that there's a distended abdomen, right? So if you remember, we said that because the trachea is also known as the windpipe, the air that is from the trachea can abnormally go into the stomach as well. So on X-ray, you might find a gas-filled stomach, which may present as a distended abdomen. And also, patient is having coarse breath sounds because remember, esophageal content is entering into the windpipe and can get into the lungs as well. So patient is in respiratory distress with intercostal retractions and all that going on, which is painting a picture to TEF. And then patient has a 2 out of 6 systolic murmur. Remember that infants usually have a physiologic murmur, which is not pathologic, so you don't have to worry about it based on the context of the question. Okay, so we have our answer right here, but why is it not pyloric stenosis? Yes, pyloric stenosis can also cause excessive vomiting and all that, but remember that in pyloric stenosis, you are not having these coarse breath sounds and then all these intercostal retractions going on. As seen in TEF, also you won't really see an excessive drooling as we see here. So this is why pyloric stenosis is not the answer. Also, Hirschsprung's disease, usually we are looking for an infant who has not yet passed meconium in the first 48 hours because Hirschsprung's disease has a different pathophysiology. You are not having, your intestinal tract is not moving, or your bowel movements are not going on as it's supposed to be due to the lack of enteric neurons or failure of neural crest migration. Therefore, the symptoms here are totally not typical of Hirschsprung's disease. That's why this is not our answer. So our next question says, what is our initial step in management? So remember, very high yield, passing an NG2 followed by an X-ray is the initial step in diagnosing this condition. We don't do an echocardiogram first. If we would do an echocardiogram, we are just going to screen for cardiac defects, and CT scan is never an option. And then they ask here, very typical in TEF question, which other test will be required in this patient? So an echocardiogram to screen for cardiac defects is the answer of choice here. So we come to the end of another episode. We will see you in the next class. Thank you. Medical board exam with Dr. Kwafu.